brochure that you bought.
Outstanding.
You can check it out like a book.
Okay, then I will do that. But thank you. Thank you to everyone in the room who's doing this wonderful work and raising our awareness and perhaps our anxiety as well. My name is Lauren Schaefer. I am a clinical psychologist and a researcher working in the area of eating disorders. And I am really delighted to be receiving a developmental award that is particularly focused on anorexia nervosa. If you're not familiar with anorexia nervosa, this is a very serious psychiatric illness, which is characterized by a pretty profound fear of weight gain and extreme dietary restriction that ultimately drives these patients' weights down to dangerously low levels, resulting in a range of severe medical complications, and unfortunately for some of these patients, can even result in death. Right now, there is no empirically supported treatment for adults with anorexia, resulting in about a third of these patients developing a chronic, often decades-long course of illness that has been referred to as severe and enduring anorexia. Now, one of the maybe key reasons that this illness is so very difficult to treat is that patients with anorexia appear to actually really enjoy parts of their illness, meaning that they find aspects of this illness to be highly rewarding, highly reinforcing. In addition, patients with anorexia deeply fear recovery, meaning that they view the prospect and the process of regaining weight to be extraordinarily aversive and extraordinarily punishing. And so the goal of this project is to try to use 3 different assessment modalities to better understand how this rather unique sort of reward and punishment risk profile might contribute to the maintenance of anorexia over time. And in particular, we'll be using EEG or electroencephalography, which we heard about earlier, to try to characterize these patients' brain response to different rewards and punishments in a laboratory setting. We'll also deploy a sort of battery of validated self-report questionnaires to try to capture more trait level, sort of cognitive and behavioral response styles to rewards and punishments in this patient population. And then finally, we'll do a qualitative interview where we'll get to directly ask these patients to describe the ways in which these rewarding and punishing experiences have perhaps contributed to the maintenance of their eating disorder over time. Now, notably, there is some research that suggests that the key processes, the key factors that maintain an eating disorder might actually kind of shift or evolve over time. And in particular, this research suggests that perhaps more punishment or fear-based processes might be particularly important during latter stages of illness, whereas reward-based processes might be more important during earlier stages of illness. And so for our project, we will be collecting data from patients, some of who will be at earlier stage of illness, some of whom will be at later stage of illness. And our hope is that we will be able to directly evaluate whether the relative importance of reward versus punishment processes appear to sort of shift over time or over the course of the eating disorder. Of course, the ultimate goal of this research is to use the information that we gain in this project to be able to develop more precisely targeted interventions that ultimately will improve outcomes for this patient population. So for example, if we were to find that maybe punishment or fear-based processes are particularly important maybe for a subgroup of patients, we might then think about using exposure-based techniques to expose these patients to feared outcomes or feared stimuli in a safe therapeutic environment in order to reduce their anxiety, reduce their fear responding in that context. Alternatively, if we were to find that maybe it's the reward-based processes that are particularly important for another subset of patients, then we might work with those patients to identify and then help them practice alternative, meaning non-eating disorder behaviors that are aimed at achieving a similar sense of reward. So I could talk about this project all day. I'm very excited to get started with it. Thank you again for TRANSCEND's support, and thank you for your time.
Hey everyone, my name is Andrew Williams. I'm a perinatal epidemiologist working in the Master's Public Health program at UND, and I'm collaborating with Peter Van Erden, who is a maternal fetal medicine specialist here in Fargo. Our project is going to be looking at a feasibility study of remote blood pressure monitoring for pregnant women with hypertensive disorders. Really, this project is informed by kind of two key pieces of evidence here in North Dakota. One is that we have really poor access to maternal care in the state. We have the highest percentage of our counties being maternal care deserts of anyone else in the country. So that relates to about 20 to 25% of our births happen or occur to families and women that live in these care deserts. And so the vast majority of these births are occurring in Fargo, Grand Forks, Minot, Bismarck, et cetera, not in people's home communities. And then secondly, hypertensive disorders of pregnancy complicate about 17% of all births in the state of North Dakota. And in the US, they contribute to about 8 to 10% of maternal mortality. So very important severe outcomes that occur with hypertensive disorders. So what we're going to do is spend most of our TRANSCEND money on buying blood pressure monitors and giving them to women to take home. There will be some training in terms of how often we want them to be tracking their blood pressure, how many times a day, how many times a week, et cetera. And then they'll also be, record keeping some of their own. And that record keeping will be a flow chart that will be available to both Peter Van Eerden, who will see the vast majority of his patients because he's one of the few MFMs in Fargo, let alone the state. But it will also be available to their regular OB and their primary care people because this is going to be linked up to their medical records. And so what we're going to be looking at with this is a lot of it will come from survey data that we have or will have at the end of their use of the monitor. And so from the feasibility standpoint, we want to understand, how are these patients meeting sort of the benchmarks for how often they're recording their blood pressure? And also some just sort of, how did you like doing this? Was this better than having to go into the clinic all the time? Because one of the care pieces of hypertensive disorders, especially late in pregnancy, is you got to go into the clinic a lot. And so hopefully what we want to do with this is minimize that. And we're hoping to see that picked up in some of the survey data. One of the other key pieces of this field in general of looking at remote blood pressure monitoring is that typically it goes pretty well. People like it. We have a better track of blood pressure during pregnancy, but we don't really have any idea if providers like it. There's really no data on how this is integrated into the clinic workflow. If providers who, are not the MFM, sort of their general OB, use the data, see the data, that type of information. So we'll be collecting some survey data from the main OB providers for all of these women as well, so we can get an understanding of how that impacts the clinical workflow and whether that hopefully leads to better care. And then we will also be looking at early readmission into either an emergency department or full, admission into a hospital in the 72 hours after birth, because that's sort of that really key point for hypertensive disorders that women would end up back in the emergency room and needing some additional care. And lastly, what we plan to do with this is obviously we would like to use these as pilot data to go get a bigger grant, do some, maybe a little bit more innovative approaches to remote monitoring. And I would love to show that it works. So we can have, Sanford or CHI or Essentia or whoever start just paying for these for their patients. Because right now it's very hospital specific. Sometimes Medicaid will cover it, sometimes they won't. So if we can see some of that change of here's a affordable, effective way to help take care of our pregnant moms and hopefully keep them alive and their babies healthier. That's the overall goal.
Hello, everyone. My name is Kumi Nagamoto-Combs. I'm an associate professor in the Department of Biomedical Sciences. My chair is sitting right there at UND. I am a neuroscientist, and my research has been focused on understanding how peripheral inflammation can affect brain function and behavior. And I've been working on that using a mouse model. So this is my very first pilot grant looking at actual human beings and trying to finding out how difficult it is to control all the strain of people and then diet of people and then a living environment. But I'm really, really excited. So what we are trying to do is have a cohort of farmers, North Dakota farmers and then non-farmers. And I kind of gained this concept as, since I moved into North Dakota from Cleveland, Ohio, 26 years ago. And we were driving around in North Dakota around this season, and when the tractors were digging up the dirt and stuff, being covered with North Dakota dirt. And then I was just thinking that, gosh, these farmers must be putting their lives on the line, inhaling these dirt. And recently I was talking to my former undergraduate student who is now pursuing PhD in clinical psychology. And then she wanted to kind of come up with some project. And then I was talking to her, and I've been always interested in how this inhaling and the farm dust could be kind of exposing farmers into increased environmental factors, environmental toxin that may be causing like inflammation in their body. So when I was talking to her, and she said, farmers have a higher rate of suicide. And then that kind of hit me that we really have to study this and then see if they are putting their lives on the danger and the risk for us to eat, have a plenty of food. And then North Dakota having 25% of workforce being farmers, I think is a really important issue for us to address. So that's what we're doing. And I teamed up with the psychology department faculty and then his team, Dr. Rick Ferrero. He's been doing this similar type of thing in a psychological point of view. And he has, several years ago, he has published a paper comparing the cognitive function of farmers and non-farmers, or actually rural residents and non-rural residents. And then he has found increased level of depression and as well as a cognitive decline in the farming population or rural population. So I wanted to take that finding further up and try to understand if there's any biological aspect that we can detect. So what we are going to do is to invite farmers and non-farmer participants to North Dakota campus, UND campus, and then our psychology team is going to assess their cognitive and neuropsychological status, and then our biomedical science team will collect their blood and then try to find the inflammatory cytokine levels, and then understand whether their cytokine levels are elevated and indicating that they are in a constant state of inflammation. And in our animal model of inflammation, peripheral inflammation, we have found elevated level of depression and anxiety-like behavior, as well as some neural inflammatory signs in mouse brains. And then we can't, dissect their brains, but we are going to try to kind of apply what we are finding from our animal models and see if we can find neuroinflammatory biomarkers in these two populations, and then try to compare. And ultimately, we would like to find some kind of find biomarkers, a set of biomarkers that we can detect in their blood, and also kind of develop a blood test that they can send off, they can monitor on their own and send it off to get it checked, to kind of monitor their health status remotely, so that because they have a lot of farmers live far away, and then they may not have easy access to clinics. So we can try to mitigate the time they have to visit a clinic to get their health checked, but they can just send off their blood samples and then get their health status checked. That's kind of what we are thinking. Thank you.
My name is Sugong Chen. I'm a bariatric surgeon at Sanford Fargo and clinical faculty at UND as well. Our research question started with I was trained in my fellowship, but we had several bariatric surgeons who have some varying techniques of doing the same thing. And some of them include drastic differences in some important parts, like cutting the vagus nerve or not. And people do one way or the other in the field all the time, and we don't really talk much about it. And there's some speculation of might make a difference and things, and but I think it's kind of hard to study, but it nagged me, and I talked to our biobehavior psychologists, scientists here that I know well, and part of my recruitment at the time, Scott Engel, is like, we're working with find some money, and they got me onto the COBRI at the time, COBRI pilot project. So we got some money to study this. So the vagus nerve gets cut or not when we make this stomach pouch for the gastric bypass. And ulcer is kind of the main Achilles heel of this operation. It happens at a higher rate than we like. Otherwise, the operation works very well for good long-term weight loss, but especially for long-term metabolic disease control. There's now more than 20-year data out. 80% of population are able to keep at least 50% or more their excess weight off, but more than that, even if people regain weight, diabetes control is still very excellent. So the operation is going to be around for a while, and it's very, very, very good for many things, but ulcer sometimes can be a bane of our patient's existence. Getting treated, we're just talking about the different drugs we use, and they have to be on not just the PPI, but misoprostol, sucralfate, and sometimes they have to manage the medications with other medication supplements, and try to make sure there's no interaction. Timing is very important. They have to take that for a couple of months, 3 months, and sometimes they don't heal. And so there are several things that affects ulcers, but nobody's looked at if we can do something different in the way we do these operations. Vagus nerve, as we all know, that contributes to acid production in the stomach, and we have done a lot of truncovagotomies in the heyday of stomach surgery for ulcer disease back in the day, and we know that. But what happens if we cut the vagus nerve halfway down the stomach, and we're trying to come across the stomach with a stapler? And my hypothesis was it may have a paradoxical effect. So if you take away the vagal signaling to the remnant or excluded stomach, the distal stomach, that distal stomach might give some feedback signals to increase acid production for the whole stomach through the endocrine side of things, so like gastrin release. So that's the chemical marker that we're going to measure, and we did, and we had 50 patients initially, and there's some interesting trends towards our hypothesis, but we don't have the statistical power. So, and then somebody showed us the TRANSCEND grant, and we applied, and fortunately we very thankful we got money for finishing this project, and there'll be some very interesting data, enlightening, hopefully change the way we practice. And as part of the two aims, one of the aims is a retrospective portion to also look at the ulcer rate, and that allows us to have access to a bigger population of patients. Now, interestingly, while we've been working on this, there's a paper been published on our retrospective portion that kind of supports our hypothesis. So that's kind of encouraging. And the vagus nerve, I think we can go many ways with this. There's appetite, um, um, effects of vagal intervention. People have been ablating the vagus nerve, cryoablation. Some of the radiologists done that, and for short-term appetite suppression with some interesting results. And there's pharmacodynamics implications if you have acid alteration in the stomach, gastric pouch. We have some in-house experts. Dr. Steffen sitting out there done some of the landmark studies that also changed our field on the way we administer medications after bariatric surgery. So we could also do some additional studies in the future. And part of this, maybe we'll be able to explore how to effectively place pH probes potentially at different parts of the anatomy for some of these future studies potentially.
All right, with that, if we have time for a couple questions to our panel.
So I have a question for Dr. Schaefer, comment for Dr. Nagamoto-Combs. Got it. Are we sure? So if you want somebody to lose weight and you don't chop their stomach out or part of it, you can give them a GLP-1 agonist. So are we sure that all anorexia nervosa is psychologically mediated? Could some of it be that they have an incretin disorder that drives them not to? Yeah. Because most of our psychological interventions have been not very successful.
Absolutely.
So, maybe paradigm.
Yeah. Absolutely. So, as I said, I'm trained as a clinical psychologist, so I'm trained to look at the individual behaviors and thoughts and emotions. But part of what's been so wonderful working with the team at CBR is we've got folks who are looking at biology and neurology and sort of helping me to think through this in a broader perspective. There is to your point that this probably is not just a quote psychological disorder, but biology is clearly involved. A team at UNC led by Cindy Bulick has identified some genetic markers of particularly anorexia that seem to have to do with metabolism. We've also seen some microbiome sort of differences in this group. So I'm absolutely confident that we're going to find that biology plays a really critical role in this patient population. And to the extent that we can sort of do more team science and bring people into that tent and work across sort of fields to look at all of these different factors, I think the better chance of success we'll have.
A comment about the farmers in North Dakota. I don't know anything about them. My first time here.
Okay.
No, it's so we set up twice. I've done this when I've been cardio in various places. Set up a heart-mind clinic. There's a very high association of depressive affective disorder and cardiovascular. And I've always wondered what the link is. Treat the psychological disorder with, at least with exercise. But both those disorders are associated with, and by the way, sub 2.5 micron particles are going to increase inflammatory response. So I really like your project because I think that I like showing that affective disorders are associated with chronic. I'll bet you that's correct. I don't know.
Thank you. Thank you so much. In the neuroscience field, the peripheral inflammation and how that can affect brain and behavior has been increasingly getting attention. And then, in the mouse models where we can control a lot of what they are getting exposed to, we do see a lot of changes in neuroinflammatory changes in the brain, mouse brains, and then most profound finding that we have is cortical demyelination. And then that is just saliently, obviously affected. So, obviously we can't look at that in the humans, but then we are associating a certain cytokine that gets released, and we are trying to, particularly we're kind of paying attention to that to see if that cytokine can be, or chemokine actually, can be used as biomarkers to test the peripheral inflammation that is affecting the brain function, then kind of trying to go from there.
Neuroinflammation, I stumbled on one inadvertently. We were studying inflammation in heart
Okay.
and create the mice hypomagnetism. And the guy suddenly thought, oh, this is great. They have like that. No, what they have is status epilepticus guy. And I'm not a very good neurophysiologist, but I look in their little brains and they're highly inflamed. So what I don't know is if they're depressed or have little mouse things. But if you want a simple model of generating neuroinflammation, I'm happy to share this. If you can,
Sure.
because it does mess up the heart.
Okay.
It increased atrial fibrillation. That's not heart. I bet you do long-term good. So.
Great. Thank you.
Yeah, yes, I would like that. In another part of my life, I'm also director for our perinatal quality collaborative for the state, and so we're I think we're meeting with the Nebraska one soon, and I know they're out of, I forget what, are you at the medical center? Yeah, I think they're based out of UNMC as well. So yes, I know you have my email in the brochure, so happy to chat, and thanks for the connections.
Well, it's a hypothesis right now. We'll see. But so the hypothesis is that if you cut the vagus distal to the gastric pouch, which is the part that we care about, that still creates acid for the small intestine. That's what marginal ulcer is. There's an ulcer of the small bowel distal to the gastric pouch. And you lose the vagal innervation. I mean, you still make acid, but you lose the, vagal mediated acid production. Then the much larger bypassed stomach might send signals to increase acid production, which will increase acid production in all of the stomach, including the gastric pouch, which already has enough acid. That's the hypothesis. Yep.
So thank you for the question. Right now, we are focusing on Eastern North Dakota, well, near Grand Forks because of the limited funding and limited time, right? But then we wanted to get a solid preliminary data so we can apply for R01 or I just found out that there's a NIH mechanism, the R61 and R33, that kind of in the first couple of years, it's you work on the feasibility of the clinical trial, and then the rest of the years you develop, now you investigate the mechanism. So those are the things that I'm kind of thinking of. But then if that is possible, then we can try to more generalize, our findings to bigger areas. And then, even though farmers versus non-farmers, but if we are looking just at the Eastern North Dakota, North Dakota and Grand Forks area, we are probably breathing a lot of what they are digging up anyway. But so if we can expand a non-farmer population or urban population to like a New York or West Coast or something like that, and that would give us a whole different population standard, I guess. But what I'm really interested in, so my animal study is in subclinical food allergy and how people can kind of eat and not have anaphylaxis, but they kind of don't feel really well. So that we are finding out that they cause peripheral inflammation, and that can affect the behavior. So I'm finding out that, North Dakota, what we grow is wheat and soy and corn. Those are common food allergens that do not necessarily cause anaphylaxis. And people can kind of tolerate it, but somewhat sensitized. So I'm very much interested in determining if they are somewhat sensitized to what they're growing. And then when they're digging it up for harvesting or planting, they're inhaling allergens that are present in the soil. And also the pesticides is very much correlated to known to cause inflammation and associated with the neurological disorders. And mold is another allergen that's living in our soil. So those are the the factors that we're interested in looking at. Thank you.
I do not. Could you tell me more? Say more. Did you say pink shift? Okay. Mm-hmm. 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 If I'm understanding correctly, you were talking about sort of body image disturbances, potentially in the context of anorexia. Absolutely, yes. This is clearly a huge component in anorexia with patients. I mean, you'll have tremendously emaciated patients at weights. You can't imagine that this person is still living, and they will look you in the eye and tell you they're too fat. It's astonishing. It begins to look delusional. And so body image and how that may be sort of playing out differently in the brains of folks with anorexia is certainly an area of deep inquiry and interest. It's not something that's built into this study. There's a part of my life, apparently we have lots of different lives up here. Part of my life, past life, was really very much focused on body image. I've sort of left that in the past as I try to pursue these very important, more biological mechanisms. But I think it remains incredibly important and is absolutely important for this patient population. Thank you.